you,
Nice to see you.
Palak. It really is. So everybody, you've seen Palak before. The last time I saw him in an online meeting about 10 days ago, I nearly died. He was wearing his scrubs and he looked like a real doctor, whereas he's just a human being with lots of knowledge about PBC today. It is though when you don't see people in that environment. But anyway, I recognised you and I didn't know you wore glasses either, so there you go.
Yeah.
So welcome everybody, and I've got questions in front of me. I've got questions will come on the screen, and Linda is going to be firing me questions, which I'll have on my wee device here, and we'll get to them as quickly as we can. Now, so we'll give you a bit of background. Palak's got some of the questions, but more will come in, and you won't have them all. So somebody was admitted to us in December with high liver levels, had an ultrasound, which is normal, and apart from 2 small polyps and gallbladder, MRE scan came back as normal. Biopsy showed acute hepatitis. Was then discharged, his levels coming down. After 3 weeks, I've gone back up, and doctor thinks I'll have PBC. So he started me on medication. AMA was slightly positive. Well, it's either positive, but it's not positive, is it? Is there anything I can do to help my levels come down? So, well, that really comes down to the medication, doesn't it?
Yeah, so thank you for the question. So just so I understood it correctly, this individual was admitted to hospital, had a series of investigations which identified gallbladder polyps, a biopsy showing evidence of liver inflammation or hepatitis, and the AMA antibody was sort of slightly positive on a subsequent test, and they were started on some medication. I'm presuming it would have been Urso. Urso. So it's a very good question. At the moment, it's unclear from what was put in that question as to what the diagnosis is. If I'm being very honest, we know that AMA, sort of is the antibody, anti-mitochondrial antibody, is synonymous with PBC for most people. Occasionally, you can see it in other types of liver injury. So if there's been lots and lots of inflammation there, we can see it in other types of liver injuries, very slightly coming up and coming down. I think it's important just to answer the question that what I would want to see first of all is the Urso alone working? So are the bloods improving and heading toward as normal as possible on Urso? In which case, I don't think you need anything more. If bloods are not responding to Urso at all in the first instance, and the biopsy just showed hepatitis only without any supporting features of PBC, so the doctor should look at that, then I would be wondering whether the AMA was is reflective of PBC or just a passing positive with another liver disease. So it's important when this situation happens not to make I know everyone wants a diagnosis, but not to say this is the diagnosis for now and forever. Actually, that the doctor follows you up and appraises the situation long term, just to see where you settle. At the moment, I'm not sure what this person has and whether it's PBC only.
Okay, so really more information required, but equally I think as Palak was saying, they do want to look at trends as well, and they want to see whatever medication you've had, they'll want to see how you responded to that as well. So maybe come back in 2-3 weeks time once you've had an opportunity to take that medication and ask some more questions if you find that helpful. So we're going on to this wonderful subject of vitamin D, which we suffer a lack of in this country, particularly up this end of the country. So this lady's been described vitamin D tablets, 1 a day for 15 days, and then 1 every 2 weeks. Dosage 20,000 IU. Is this correct? What's IU?
So IU means international units. So just like we have milligrams or micrograms, IU is another. And I mean, you can buy vitamin D from Amazon or from over the counter. Usually they come in 400, 800, 2,000, 4,000 units is the most you can purchase over the counter. It sounds like this individual's vitamin D values were quite low to be given 20,000 units. Now, normally, I mean, the practice varies. There's no right or wrong dosage because it's a vitamin. But if your vitamin D blood values are below 30 or 40, then 20,000 units once a week it's not unreasonable. I tend to go slightly higher. So if somebody's got vitamin D values in their 20s, then I would give 50,000 units of what we would call cholecalciferol. That's just a formulation of vitamin D, a particular type of vitamin D, once a week for 5 to 6 weeks. It really depends on what the blood value is. It may be that this individual's blood value was about 40 or 35, 40, and that's why 20,000 units were given once a week. And normally that continues for about 5 to 6 weeks. The vitamin D value is rechecked, and then a daily supplement at a much lower dose, the over-the-counter dosage I was mentioning, somewhere between 400 to 2,000 units, is then taken daily to prevent it falling down or reduce the risk that it falls down over time.
Yeah, and not to come and live in Scotland as well, because there's virtually no sunlight here.
Yeah.
I hope you find that helpful. That was quite interesting. So it comes up quite a lot, the vitamin D question, Palak.
Yeah, I mean, some studies have found an association between not responding to urso and being very low in vitamin D. Now, whether that's a cause, i.e. the vitamin D is the cause, or whether it is just a reflection of more aggressive PBC, we don't know. But if an individual with PBC is not responding to urso, one of the things that we do is check the vitamin D and replace it in parallel to evaluating for other medicines need.
It's maybe worth saying to people, maybe we should always have our vitamin D checked when we get our visit to the hospital.
Yeah, I mean, it's certainly worth. I mean, vitamin D, because it does vary with sunlight. People who live in colder climates, anybody who's say above the age of 45 or 50, we always say in winter months, just take a daily supplement to prevent your levels falling. Yeah. I mean, there's lots of COVID studies showing that people who've got very low vitamin D have worse outcomes if the vitamin D is low. So what we always say is in the winter months, just supplement vitamin D, just with over-the-counter, vitamin supplements, multivitamins, or vitamin D on its own. And I tend to check it in people who have fatigue, because it's a contributor to fatigue, and people who've got thin bones. We always check vitamin D for them. Yeah. It's not worthwhile perhaps checking it depending on how often people are seeing, but I don't tend to check it more than every 6 months, unless I've instituted a course of replacement and I want to see whether the replacements work.
Yeah, no, it's quite interesting. Thank you. Yeah. Okay. Does having red palms, if you have PBC, mean you have cirrhosis? I haven't heard about red palms for a long time. And in the old days, Palak, in the old days before you were born, before urso, quite a lot of people I met with PBC did have red mottled palms.
Yeah. So, I mean, red palms can mean many things, and I wouldn't say it always means cirrhosis. That's the first thing, because there are a few causes. So, in people who have cirrhosis, the way that the blood pressure, the heart rate, is regulated changes, and one of the features that we can see is what we call palmar erythema. So these sorts of portions of the hands tend to get a lot more red, and in people who are jaundiced, the middle bits tends to stay a bit paler, and that was a sort of feature now. But alongside that, PBC itself is associated with some conditions. There's one particular condition called Raynaud's phenomenon, whereby the blood supply to your hands is not regulated well, and you can get discoloration of the tips, reddening elsewhere, and then your tips become red, and it's sort of your hands sort of change color depending on the weather. That's the other thing. And the pinkness and redness of the palms change alongside naturally with age in women. So women who sort of go through the change, and in later life their palms can become a bit red, can become a bit pale. So I wouldn't say it's always associated with it. If people are interested, I can certainly sort of send Collette and the foundation a characteristic picture that we use for learning and teaching students about what the red palm of cirrhosis looks like. Just to sort of see, just if individuals wanted to, just for interest.
Well, that would be quite interesting, because it's a long time, like I say, since I've seen it. Great. So can you take sage capsules for premenopausal hot flushes when you have PBC?
What's my AirPod? Just 1 second. In the background. So so you can take sage, capsules. I don't think there's any harm in taking sage capsules. Admittedly, I'm not completely aware of the benefit of them in sort of in menopause. I think it's very much anecdote, but there's no harm as such to the liver for sage. I mean, it's just a wild herb, really.
Yeah, well, they talk about sage tea as well. That that I've heard people talk about sage tea, but whether it helps or not. But whoever's asked this question, if you're really suffering with hot flushes, and they can be awful, and I do say this, having been through that a million years ago. I mean, do chat to your GP about it. You know, there's lots of things, and some people, well, PBC people do well with patches. You know, HRT patches for a little while, just to move things along a bit. So don't suffer. They're horrible. Yeah, they're absolutely horrible. I do sympathise. So, lady AMA positive by 6-7 units. LFTs normal. Good. The GI doesn't think she has PBC because her LFTs were only slightly raised 3 months last year. She'll be having another blood test soon. The doctor's ordered an ANA and immunoglobulin G test. So our ANA and immunoglobulin, I can't say that word, G test.
GG, yeah.
Right, okay. Are they biomarkers for a diagnosis of PBC? It's a good question, actually, Palak.
Yeah. So IgG is not a biomarker associated with PBC, but it may be elevated in people who've got any form of autoimmune condition, including PBC, but it's not specific, is what I mentioned. But ANA is perhaps slightly more sort of recognized. So there are ANA is an umbrella description for anti-nuclear antibodies, and of which there are many, and there are particular.
I can't hear. You're back.
Oh, sorry. Yeah. There are certain subtypes of ANA which are associated with PBC, and not all of them are. So the two in particular which we see with PBC, there is an ANA subtype called anti-GP210, and there is an ANA subtype called anti-SP100, which we check. And all they really mean is when we look for the antibody, where are they located on the cell when you look at down a microscope, the pattern that they pick up. So those two things are associated with PBC. For this particular individual, though, I wouldn't say that completely normal blood tests now, but ones that have been abnormal in the past, would exclude the possibility of PBC. We know that anti-mitochondrial antibodies, AMA, can be found in people without any problem. We see it in about 1 in 16,000 people in the population who don't have PBC. So if this individual has any symptoms of PBC, if this individual has got a family history of PBC or has got other autoimmune diseases, then I would perhaps be more comfortable with them being followed up in a hospital setting and just monitored. And if there's any slight hint of blood test abnormalities from a liver perspective, I would probably start urso. But if none of the things that I mentioned, so no family history, no other autoimmune conditions, no symptoms of PBC, and the bloods are indeed completely normal, then just an annual liver blood test would be all that I would recommend.
Yeah, okay. So background, diagnosed with PBC in October, and so started taking urso then. Had a bad bout of biliary colic due to gallstones in November. Oh, how awful. Just had some bloods done, ready for the checkup. Looks like my GGT have come back into range. I think they mean normal. GGT was 311 in October, and it's now 64. I'm on meds for IBD, and they are delayed release capsules that open in the colon. They're a form of NSAID. Is there something to be? Is this something to be concerned about? Am I non or partial responder, or is it too early to tell? Brilliant question.
Yeah, it's quite. Yes, I just so I because it was quite a long question. So I think this person had stones and has also got inflammatory bowel disease.
Yeah.
And has been given a medication that has partial release in the colon. And they're asking whether this means that they're a non-responder. Is that right? Am I missing any points there?
Yes, they are. And there's saying that the GGT is coming back into the normal range, but of course the GGT isn't the marker really for normal PBC. So I would quite like that explored if we can.
Yeah,
And they're asking, is it something to be concerned about?
Okay, right. So, I mean, GGT and even ALP or alkaline phosphatase and bilirubin, all of these are markers associated with liver and bile duct problems. So if this person has had gallstones and problems with gallstones, then it may be that sort of caused them to become elevated. The fact that they're coming down is a good sign, and I suspect it does not reflect PBC, but without sort of seeing you and sort of just seeing the trend over time, I can't be 100% certain, but I think it's unlikely. I think it's more to do with stones than anything else. In people who've got inflammatory bowel disease, what we see is that if the bowel is inflamed, that can also cause the liver enzymes to become elevated, because your liver transmits most of its blood supply to, your bowel transmits most of its blood supply to the liver. And if your bowel isn't happy, then your liver's not that happy. So it may be that's a reflection of why the bloods have risen transiently and then coming back down. So I wouldn't be worried that you're an ERSO non-responder based on what that person has shared so far.
Yeah, and I think it's important to say as well, the gamma GT, the GGT that's talked about, and just to be personal for a moment, I have lost 3 stone 9 pounds, and my gamma GT has come absolutely flat back to normal. And so my doctor says to me, you've obviously had a bit of fat in your liver. So gamma GT is really what I'm trying to say. It's not all about PBC. It's really the alkaline phosphatase that's important, isn't it? So that's fine, but that's something for everybody. People have put on COVID weight, and nobody's being judgmental here at all. But if you have put on some weight, do bear in mind that it can reflect on your liver function. But also, you're going to receive one of these in the post, and this is have you seen this, Palak? This is our ERSO calculator, right?
Nice.
So it's imperial and metric. And we're sending everybody out one in the post. It's going to be our website. Keep an eye on your own weight. I mean, don't depend on your doctor to do it for you. The chart's there, and you get any questions, give us a wee ring. Just take control, isn't it?
Yeah. No, excellent. That's really good.
Scales are tools of the devil as well, I have to say that. Sorry.
No, the one thing I would just add actually about gamma GT and ALP, if your gamma GT is completely normal, but your ALP is still a bit elevated, the ALP is made from other parts of the body. So it can be made from your bowel, it can be made from your bones, and in children, we don't check ALP because it's made from bone mostly, and we use gamma GT as a sort of I mean, children don't get PBC thankfully, but it's in liver disease generally that's what we use. So if you've got a normal gamma GT but an ALP that's still elevated, just ask your doctor sort of just, are you sure it's all coming from my liver, because it could be coming from somewhere else. And people who have fractures, for example, can have very high ALP.
That's quite interesting, actually. I never knew that. Not that there's any reason to know it, but that's very interesting. There's another question on another page. How long does it take for your results to come back into range? Well, that's how long's a piece of string, really, isn't it?
Yeah. I mean, we do want we assess the response to ERSO at usually around 6 to 12 months. 12 months, obviously, more people will come in range, but you can usually tell that if there's been a decline in that 6-month period, that's a very good sign. But usually we give you a year's grace to see how close to normal, but a year is a little bit flexible. I mean, if we can see you're almost there, then it's not an absolute cutoff, but a year is usually what we would wait for.
Yeah, I think it's important to say as well to everybody that with blood tests, it isn't one blood test, it's trends that the doctors are looking at, because other things can cause your liver function or your liver enzymes to be a bit in disarray. And so they look at trends. They know what they're doing. So here we go. Thank you, Palak. Background: diagnosed a year ago. I've been on ERSO for 10 months. Suffering hair loss and itching. I would say I have lost 30% of my hair, which was fine to begin with. I also have intermittent itching, which moves around. My FibroScan normal, ALP 150. So the questions are, is hair loss a side effect of taking Urso? If so, is there anything I can take to help? And any suggestions to help the itch? Well, I'm sure you do.
Yeah. Okay, so two main questions. One's around hair loss and the other one's around itching. So, I mean, I wouldn't say hair loss is a feature of PBC, but depending on how unwell you were before you were treated, the human body, when it perceives itself as being ill, then things such as hair growth, turnover of skin, they become very slow. And in some people, even hair growth tends to stop. And then when you recover and you're getting better, the new hairs push out your old hairs, and you start to notice a bit of hair fall. And there's a very long medical jargony term like, for that, that's called telogen effluvium. And what we tend to see is that people who've got very hairy forearms, like me, for example, so that when they're on the wards, here in the hospital because they're very ill, they notice all the hair sort of going, and and some people, particularly women, because they tend to have longer hair, not always, they sort of notice that some of their hair is falling. It does recover and it does go back to normal, but it takes a long time. It can take months and sometimes years for that to return, but it is a common phenomenon. So I presume that that's what's happened to this individual. They were unwell, they've been given some medicine, and now the hair loss has come. The other thing, of course, is if you're itchy, is whether subconsciously or consciously you're scratching a lot, and it's important just to have a check for that. Now, itching is sort of obviously is a very well studied but still incompletely studied area in PBC. The two important things that I would say, if you're going to take anything away from today and previous talks, is first of all, don't assume the Urso will treat it, because it doesn't. The only Urso is useful for itch and other health conditions we see in liver medicine, but does not tend to help most people with PBC. There are a few people, but it's the exception rather than the rule. The second thing is, please don't suffer in silence, because we have several medications that we can use to treat itch that are much more specific and supported by good quality evidence. As with any treatment, of course, there are still, sadly, people who don't respond to the currently available medicines, but we have lots and lots of new medicines undergoing clinical evaluation that that you would be open to have. So we have lots of things to to treat itch with. I mean, I'm sure by fact, I think I've definitely seen something about this around itch on several issues before. But one thing is around itch, I would certainly say, is the first line treatment we give is a powder. It's called cholestyramine. Doesn't taste very nice, but it works in about 40% of people. There is an antibiotic that works really well called rifampicin. There is there are slightly less commonly used agents called naltrexone, sertraline, and even a medication called bezafibrate, which work well for itching. So certainly, if your itch is persistent but your bloods are better, please do talk to your doctor. I normally would give it 3 months, maybe 4 at the very most, in somebody who's got mild itch when I've started Urso, just to see by chance if it gets better. But anything more than mild, we should be treating in parallel with Urso, not waiting to start for Urso to do something, because it probably won't.
That's really quite helpful, and it's quite comforting to know. And do bear in mind, everybody, that the severity or non-severity of their symptoms don't relate to where you are with your PBC. It's not a case of further down the road that everything's going to get worse, because it doesn't. It really does not. And it's important. I'm going to throw this in at this point. It's important you look after yourself. And I've said this in the latest Bare Facts with, drinking plenty of this. We're a nation of prunes. You've no idea how good that stuff is for you. Water and a good diet, not loaded with sugar and processed foods. Have a bit of everything, a bit what you fancy. But also exercise and movement is medicine. This is a fact. It's been established. I don't know, are you in a position to, if your thing's been printed, can we take something from you to maybe get the Bare Facts sometime?
Yeah, so we've certainly presented the data around a study looking at certain exercises improving fatigue.
Yeah.
It is actually in the process of being written up. So one of our physiotherapy colleagues, Alice Freer, actually this morning emailed me a first draft of it. She's just returned from maternity leave.
Right.
So I need to look through that. But in short, we've presented the study findings at an international meeting just over a year ago now, before Alice went on maternity leave. And it showed that out of, I think it was out of 35 individuals, 33 actually normalized fatigue levels to that of the general population, with specific types of exercises that we had taught them how to do. It was a proportion of people who did not have very advanced PBC, because that adds to the fatigue in a different way. So people who've got very severe, liver disease will have fatigue from that as well as from PBC in itself. So from that point of view, I think it's really important just to sort of take home the fact that our study will, when it's printed, it will be very clear as to which people it has benefited and which people we did not include in that particular trial and why we didn't include them.
Yeah, well, we'll get something from you later on. Excuse me moving around all the time, by the way. I've got a trapped nerve in this.
Oh gosh. Yeah.
I'd surgery years ago and it's come back to haunt me.
I was going to make a hemorrhoid joke then, but I'll leave that for offline.
Never had them. Never had them. I haven't. Going back to the hair loss thing, this question was once presented to Vinod. Do you know Vinod?
Yes.
So just everybody, he's a consultant at St James's in Leeds. And I've known Vinod since he was just a wee bairn, really, since he was very young.
Yeah.
And he said, because he does a lot of work on itch, well, he did do, as you know. And he did say that he'd heard this from time to time about arso and about hair loss. So what Palak was saying is absolutely right. There is that, because you hear of hair loss if you, with long COVID. So some people have said post-COVID that they've had hair loss, etc. And I've seen it, the newspapers, Dr. Ellie, she has said it does come back, but the body's got to recover. But it's an interesting one.
And we see it in transplant recipients quite often.
Really?
Yeah, so they were very unwell before they were transplanted. The transplant has made them better. And once the internal recovery started, then the peripheral recovery around hair and skin.
The hair comes back.
Yeah.
That's quite good. Just going back on the fatigue as well. So you were saying that your physiotherapist, I'm delighted you're writing up. By the way, everybody, let me tell you, my physio said to me last week, who I'm seeing for my trapped nerve, doctors save lives. Physios make it worthwhile, right? If you've got any unexplained pain or any difficulty, physios get. Her husband's a doctor, right? So I quite like that. But I would go back on to say some years back, was Professor Mike Trinnell worked in Newcastle with David Jones on the fatigue thing, and what they established that people who were needing a transplant were on the transplant waiting list. They were becoming too unwell to withstand the operation, and they put them on a very light, gentle exercise program, and it made a difference to their general health. So this is pretty good stuff that's coming down the line. And it does make you feel better, even if you've got a trapped nerve like what I've got. Yeah. Okay, right. So next, I'm waiting for liver biopsy. Oh, I wonder why. Right. I have PBC, I'm on urso, but it's still not working as well as it should. Upped dose, so now waiting for the results. Blood's being done. Questionary overlap, PBC and autoimmune hepatitis. Is this a regular thing?
It's a very good question. I mean, So biopsies are rarely performed in routine practice if you have PBC. We do not tend to biopsy all individuals who are not responding to urso before making a decision to start additional therapies. There are some occasions where we do, and the two that I think of and of doing a biopsy in somebody who's not responding are, number one, if we think there's lots and lots of inflammation there, that would benefit from suppressing your immune system for a time to settle it down. Now, PBC, there are very few people, and I must emphasize, there's very few people where it can evolve to another type of autoimmune liver condition called autoimmune hepatitis. And when I say very few, I mean, we've got sort of more than 800 people who come to our program with, here. And usually in a year we might see, so 2 or 3. So it's very rare.
Very small,
Small. So in those circumstances, we just want to see if actually there's so much more inflammation than we would expect. We might give you something, to settle that down. The other type, the other thing to differentiate from that, there are some people whose bile ducts are affected more so than we would expect for the amount of scar tissue that's there. And that particular type of PBC is important to distinguish from that, from the inflammatory type that I was talking about. But again, these are very, very rare cases that we would see now and again. And the reason I mentioned the word cases rather than patients or people is because these are the sorts of things that you read about more often than you see. So that's the reason, because it is uncommon. Now, for this particular individual, there may be another reason that they're biopsying sort of them. It may be that sort of the reason that they're undergoing a biopsy is because there is a medicine that is only suitable to treat beyond a certain degree of scarring in your liver or a certain type of staging in your liver. So there was a something that was printed by the British Gastroenterology Society around when to do a biopsy. It was published by actually a doctor you may know, Collette, who works in Scotland, called Mathis Heidman. And in that, it sort of said that you have to biopsy people with PBC if they don't want to urso. And it got a lot of backlash from myself and other colleagues who work in the field. And hopefully they've retracted that particular statement, saying that that's not necessary. But I'm hoping.
You've got your ears.
Oh
yeah. No, when I think they're slipping out, and then I can't hear you. You see? No, I can't hear you.
Hello.
That's it. I can hear you now.
Oh, sorry. Just 1 second. Yeah.
Yeah. No, that's an interesting point.
Right, okay. No. Yeah. No. Yeah, no. I think it's because I'm calling from my phone. Every time someone rings, it goes off.
Oh, I see it's happening. Right, but the biopsy thing is interesting. So I know in the old days,
yeah.
And it was you won't know him now. He's long retired. He's in his 80s.
Yeah.
Dr. Neil Finlayson up in Edinburgh, who was trumpeting no biopsies, no biopsies.
Oh yeah.
Because it was pre-ultrasound days and when they were serious. But I've had PBC in 20 years, and I pass him in the street and he'll say to me, "Have you been biopsied?" No. So you're absolutely right. They were being done willy-nilly, and it was just a nonsense bit.
Yeah.
And anybody.
But I'm sure there's a reason for. Yeah, I was just saying. I mean, to this individual, I think is just ask the doctor what they're looking for in particular. Just ask them. It may be something that they're just trying to see. Is it still PBC, or is it a certain type of PBC that would respond to a treatment that we don't usually use? That's all.
Yeah, don't be afraid to ask questions. I think that's really the message that Palak is going to ask and discuss. And you're not being silly. It's normal. They're doctors. These are invasive things. They understand that you need to know as much as possible, and they want you to ask questions. They're not offended. It's not like it was in the old days. Right, here we go. Thank you, Palak. Please, can you tell me what a spinal renal shunt is? Just had a letter from the local hospital following my MRI. Spinal renal shunt.
So splenorenal means a connect. So it refers to your spleen. That's the first part of the word, and renal refers to your kidney. That's the second part of the word. And some people are born, or they may form a sort of a connection of blood supply from their spleen to their kidney. Now, and it's a variant. It's what we call an anatomical variant, because some people are just born with it, and it means that they shunt a degree of blood away from the spleen down to some of the blood vessels to the kidney and then back up again. Okay, which is so that's just sort of it's almost like something that some people are born with. It's rare that they form spontaneously, but we do recognize them. That sometimes that can that in particular sort of that can happen where that sort of where the blood can shunt And often we pick it up when we are doing scans because you've got a liver condition.
Right. Okay.
Yeah.
Okay. Thank you. So I'm shifting about in this seat. Here's that question you will be able to answer quite easily. Do you know anything about beta-colic acid for PBC? A trial drug possibly for me at Addenbrooke's in Cambridge. Is it trial? What's going on here, Palak?
So I mean, there is a trial ongoing, but so a beta-colic acid is what we often start individuals on if they are on URSO. And whilst URSO may be helping, it's certainly, I'm sure it will be, the addition of a beta-colic acid is thought to help even more. And importantly, for most people, it is an addition. It is not a replacement. Please don't stop the URSO like some people have done. And it's important to take both agents to slow down the rate or stop your PBC progressing. So it's an additional treatment that we use, and it's been published for a while. It's been used for a while following publications in 2014-15, and it's an agent that's been used in thousands of people across sort of the world, and we've got lots of data from the UK showing that it is safe and it works. It is something that it's designed to normalize or at least sort of reduce your liver blood tests from where they are and bring them down as close to normal as possible with URSO. The only time we use it without URSO is if you can't tolerate URSO, of course. In terms of trial, I mean, there is one trial that I'm aware of in the UK, well, two trials I'm aware of in the UK, where but it is used routinely in clinical practice. There is one trial in the UK which has stopped recruiting new people, is in people who've got very, very advanced PBC to see if it makes a difference. And that trial is sort of stopped recruiting new people. It's going to sort of, and that's mainly because a beta-colic acid is available routinely now. You don't need it just in a trial. And there is another very small trial which sort of being run to see whether addition of a beta-colic acid and another drug that we use called bezafibrate together are very helpful. There will be a third trial, a very large trial starting later on this year, to see if people who, when they're first newly diagnosed, whether giving them URSO and a beta-colic acid from the beginning, so without waiting to see whether they fail to respond to URSO, giving it right from the start is better rather than waiting a year to see what URSO does and then adding it in later. But that trial it's very much in its infancy. We are currently writing the protocol. I was with David Jones and George Mells, and glad to say in person actually on Tuesday, and we were discussing the protocol then. So it'll probably launch to recruit new people toward the end of this year, Q3, Q4. And hopefully nobody on this call will want to do the trial because you've all been diagnosed with URSO, diagnosed with PBC, and you're on URSO already.
And we're all sorted, absolutely.
Yeah.
And if this person's in Cambridge, more than likely you will be seeing George Mells, Dr. Mells, who's just a star, isn't he? He's great. And protocol, rather you than me, 175 pages. Anyway. Now, here's an interesting one here. I'm going to say a couple of things before I hand it on. I was diagnosed with long COVID and have peripheral neuropathy. Huge sympathy, really. Reading Health Unlocked forum, several people also had it. Is it a symptom of PBC? If so, are there any painkillers or treatment? It's particularly bad at night, my legs and feet. Before I hand you over to Palak, we have a Health Unlocked site, and it's something that worries me, Palak. We've got to have it apparently, but somebody will put symptoms in, and other people trying to be helpful quite often say the wrong things. I mean, one lady who somebody made the comment, oh, if you're putting on weight, just come off your URSO. And there's silly things going on. So if you're on Health Unlocked, do come to us, which you have done with your question. I'm really pleased about that. But just be careful what you're reading on Health Unlocked, because there's well-meaning non-experts all over Health Unlocked. So basically, this person's got this horrible peripheral neuropathy. Is it a symptom of PBC? Are there any painkillers or treatment that's particularly bad at night in my legs and feet?
Oh, I'm very sorry. I certainly sympathise with this individual. I mean, pain is when I say it's difficult to treat, what I mean is the same agents may not work for the same, for everybody. I mean, there is a common misconception that things like paracetamol can't be taken if you've got liver conditions, which is not true. Taking them within the recommended daily limit, 4 grams, 8 tablets in 24 hours is perfectly safe. And often paracetamol enhances the effect of other painkillers that you may be allowed to take. The only painkiller I would say you should not take if you've got any form of liver condition are anti-inflammatories or non-steroidals. Now, there are a very few people who for very strong reasons do take them, but again, they're the exception. So ibuprofen, Nurofen, naproxen, those agents, sort of should not be taken. Aspirin is okay, but other agents sort of, that I mentioned should not be. There is an agent called, codeine, which some of you may have heard of, tramadol, and even morphine, for example, which your doctor will prescribe. And we tend to avoid them in people who've got bowel problems or who've got very, very, very advanced PBC, where their liver is not able to filter toxins to go, and those toxins can go to the brain. And the reason we avoid it in those people is it can make you feel a bit more drowsy. But broadly speaking, paracetamol, any sort of codeine, tramadol, morphine are okay. There is another agent that we use called nefopam, which is and that's it's actually derived from caffeine, and it's not a morphine based painkiller. It is very safe to take, and people sort of when they take it, they don't experience many side effects. It does have a bit of caffeine in it, so we don't advise it to take before bedtime. And then there are other painkillers like amitriptyline that we sometimes use, which are good for nerve type pains, which this individual may find useful. And I mean, and if it's pain in the feet, then there is something that you can get over the counter. It's actually derived from from chilies. It's called capsaicin cream, and that tends to sort of provide sort of be quite a good remedy. At least people report it works well for them.
Yeah, I've heard of that for shingles pain.
Yes, exactly right.
Which is nerve pain, which is pretty awful. Now, I'm not sure how much this question here is part of PBC, but it also stands alone. Why does Sjogren's syndrome cause double vision beside dry eyes? Now, I know lots and lots of people with Sjogren's. Double vision's a bit of a difficult one.
Yeah, I mean, I can't. I mean, I'm afraid to say I'm not an eye specialist, so I'm not. Well, so I do know about Sjogren's syndrome in the context of PBC. I can't say. Afraid.
I'm losing you, Palak. Maybe your phone's ringing. Oh,
there you go. Yeah. Can you hear me okay?
Yeah, grand. I've never heard of double vision with Sjogren's.
Yeah. Yes. No, I haven't actually either. I'm not completely. I'm afraid I can't really. I can't really.
I would urge this person very much. Do look after your eyes, your eye health, with preferably oil-based tears, artificial tears. But I really would like you to go back to your doctor and or your ophthalmic people and get some answers on this, because it's not something that I have much or you have much knowledge of. Okay, diagnosed in August, had first checkup last month. My levels are about the same, having taken Urso for 6 months. I have eczema and PBC itch mainly on my head. I'm taking 4 grams of cholestyramine light for 4 months and it's not working. What itch solution should I be looking at? Well, of course, you did cover. Before you answer about other medications, if we can say again, is it not important when you take this cholestyramine, the Questran? Is it before and after food in the morning? Now, that's how it used to be years ago. Is that still the same, Palak?
Yeah, no, it's a very good question. We do realise that cholestyramine tends to work better in people if they've got their gallbladder in. That's just something that we've observed. But not to say that it doesn't work in people without gallbladders. It's just that the best results are seen in those who've still got one. We tend to advise, certainly in terms of medication, to take at least an hour after, and at least 4, preferably 5 sort of hours before your next lot of medicines are due. And that's because it sticks to everything. It can stick with lots of different things. In terms of food, I don't have a particular preference because it doesn't taste very nice. And there are actually NHS Highland, out of all places, have published a very nice resource which you can sort of Google. If you Google "cooking with Questran," it's not a daytime TV show. It's actually a nice PDF document, and it comes back and you'll get this PDF document telling you which foods you can actually mix the Questran in with, so the Questran taste goes away. And it also tells you what types of cooking meals and stuff you can mix it in with, where the sort of the food goes away. Sorry, the taste goes away from the food, and the taste goes away from the medication. So I don't particularly prefer to say you have to take it with food. It's just often a bit more palatable to do that.
Right. Okay. So the same which solution should I be looking at? Well, of course, you mentioned the antibiotic. What's it? Rifampicin.
Yes.
Is the next line treatment, isn't it?
Yeah. So rifampicin is what we tend to use second line. So rifampicin is an antibiotic actually that we used to use, well, we still use it to treat tuberculosis at a very, very high dose. But we use it at a fraction of the dose. So for example, for tuberculosis, you would use 600 milligrams to treat itch. We would use 150. That's a quarter of that. And you may ask, well, how does it work? Why would it work? Well, some of the bile acid receptors can be targeted by rifampicin, and because there is a good body of evidence that whilst it's not the bile itself, it's some substances in the bile that trigger itch. That's why rifampicin works, because it targets the production of sort of a bile in that particular way, and it's a very nice sort of medication actually. It's sort of in some people who've become, there are some people who are very jaundiced where we've given rifampicin and the jaundice goes away. It sort of helps bile flow better. So it's a very nice medication to use.
Oh, great, good. You've got a very good question here. Can anything be prescribed for fatigue? I have gone from being a very active person to not being able to function on some days. I'm well aware that exercise makes me feel better, as I've always done some kind of activity.
Yeah.
Actually getting the energy to do it in the first place is so difficult. Now, I've got huge sympathy with this person, and I understand exactly what they're saying. And I would suggest, you just don't, it's emotional, psychological. You need that room to make yourself go and do the physical. And I mentioned just the other week, I was telling David Jones, I read a book by Mel Robinson, an American author, and it's called The 5-Second Rule. And it's a very interesting read. I had it, in fact, I put it on my earphones when I was walking. It's an audio book. And she procrastinated, she was tired, she didn't have the energy. But she discovered 5, 4, 3, 2, 1, go, and you build a new neuropathic pathway, and she does it automatically. She doesn't even think about it. And she had difficulties that you couldn't begin to imagine. And that's just really the kind of thing that we should be looking at, out with, the normal getting on an exercise bike, walking around the block. There is this emotional, psychological part to it, isn't there, Palak? And you would have put that in your studies and the trials.
Yeah. So, I think for this, this particular individual is saying that they already exercise quite a lot, or they already exercise as part of their routine, which makes them feel better, which is a good sign. So credit to them. I know it's not easy getting started, and by no means are we going to say that our exercise trial is the only thing that will ever help with fatigue. What we're saying is that it certainly helps fatigue and it reduces the severity of it, but there are many things that contribute to fatigue. For example, what we recognize is that PBC can have a wealth of different symptoms, including, for some people, brain fog, or what medical personnel would call cognitive impairment, and that may be contributing to fatigue.
Yeah.
PBC is also associated with lower mood, which also contributes to fatigue.
Yeah.
So it can be associated with building up of acid in the muscles, which contributes to fatigue, which is where the exercise comes in. So this particular individual is asking for, I suppose, for additional things beyond that. The first thing is often, treat what we can treat while working together. So things like vitamin D deficiency, thyroid problems, insensitivity to or intolerance to gluten, anemia. All of these things need to be checked first by your physician to see if they're a contributor to your symptoms that can prevent you feeling as well as we can get you. There is a body of work now showing that people may not regulate their blood pressure or their heart rate as normally as they should. That's got a very long name called autonomic dysfunction. But there are tests that we can do to see if you have that, and there are mechanisms that can be done to remedy that. So treating what we can treat is the first thing, and remedy what we can remedy based on that. Beyond that, if it is a type of fatigue that means you are quite sleepy in the day, despite having a very good night's sleep, then occasionally we may offer, and it's not based by good evidence, but occasionally we may offer medications that may help you stay awake during the daytime. If it is a particular type of fatigue where literally you just don't have the energy to go and do things, then unfortunately at the moment there are not a particular medicine that's available that's proven to help with that beyond the things that we measured around exercise and other tools. However, there will be hopefully later on this year a trial looking at certain types of certain changes, certain chemicals that alter the balance in the body to try and give people more energy. So some people have heard of this thing called Q10, which has been trialed before, hasn't really been shown to help people with PBC, sadly, but it's based on that premise. It helps reset the body's balance a little bit better. So whilst the answer may be a bit disappointing to this individual, I just want to extend my full sympathy and say that there are a few things that would need to be looked for and adequately addressed before we say there's nothing that we can do.
Yeah, I think that's right. And I would say to everybody, and you've heard me say this many, many times, if there's any change, and if all of a sudden your tiredness, your fatigue is worse, the amount of people I've spoken to, and I've said, go back and get your blood checks, a lot of the time it's been thyroid disease and some other things as well. So never hesitate to go and get some more blood tests in, just because we get other things as well. So there we go. Palak, I was hoping we'd have it short. I know you're absolutely crazy busy in the hospital at the moment.
Okay.
So thank you so much for joining us. I think we've done the question. I'm going to let you go because I know you're working flat out. You're doing a grand job. Thank you so much for joining us, Palak. And thank you to everybody in the background who work away. And to everybody out there, thank you. Keep the questions coming in.
Thank you.
Yeah, thanks very much.